All right. Hello, everyone, and welcome. Today, I'm really excited to talk to a specialist, Danielle Valette, physical therapist, who is as much of a specialist in scoliosis as someone can be. So without further ado, let me introduce Danielle Valette is a dedicated and innovative physical therapist and entrepreneur with over 25 years of experience specializing in orthopedics and spine conditions. She is a respected clinical educator and speaker, sharing her orthopedic and spine expertise across the United States and Canada. For the past 7 years, she's focused extensively on scoliosis and spinal deformities, becoming one of the few physical therapists in the U.S. to hold all 5 major evidence-based scoliosis certifications. 5, that's impressive. Danielle opened ScolioAustin in Austin, Texas in 2019 as a niche practice, I always struggle with that word, practice dedicated to providing proactive, conservative care for individuals with scoliosis and spinal deformities. Her approach emphasizes individualized treatment plans grounded in research-based methods. Danielle, welcome.
Thank you. I really appreciate you asking me here.
I thank you. You know, this has been really important as I work with people who have osteoporosis. Many also have scoliosis. So what we're going to talk about today is not just the overlap in care, but how someone can really determine, might they have scoliosis if they don't know as an adult? What are the similarities and differences of treatment? Is there an increased risk for fracture? What kind of modifications or specificity needs to happen, right? We're going to cover all of that today. So first, go ahead and tell us a little bit about how you came to be working as a true specialist in scoliosis care.
Yeah, I mean, the journey has come from basic orthopedic when I was in my orthopedic clinic and just seeing all these complex spine conditions. And as physical therapists, we're always trained that we can handle pretty much anything. And I kept feeling like with especially some of these older patients that were coming along, there was such fragility in the spine and such complexity. And if I couldn't visualize what was happening, then I started giving them things that maybe weren't as helpful for them or short-term benefit or sometimes even made them feel worse. And that's the worst thing for a physical therapist is when you give somebody something and it hurts them. And so I started really looking into what there was out there because many of us in physical therapy don't even know that there's a SCHROSS certification out there for physical therapists. And so once I started down that rabbit hole, then I was humbled. I mean, at the time that I started this specialization, I was a physical therapist for 15 years. And, you get pretty egotistical about, I can handle anything that walks through that door. And then I was humbled by how poorly I had been visualizing what had been happening and treating what was happening. And really, even if I was treating something correctly, because scoliosis is such a dynamic movement, you have to really be stabilizing at the same time you're treating. And those things were just not taught to us in PT school. And no matter how good of a therapist we are, we just don't have the educational background to identify certain things and look at them in a certain light.
Yeah, that's that whole I don't know what I don't know sort of thing. I experienced that same sort of existential crisis through my career too, and understanding like even just pain neuroscience and a lot of the things and how we work with people. But the wonderful thing is, you said I'm going to continue to seek knowledge and learn more about how to do this.
Yeah. And it really, and then, part of yes, I've got 5 certifications, but in all honesty, it's like with our licensing requirements of having to do, 30 hours of continuing education every 2 years, it's like, why would I go off and do another shoulder course or another knee course? I mean, so I just I kept doing more of these certifications. And I just found that because there was nobody, I was for the most part working in my own clinic. I wasn't working around people who understood this. Really having that opportunity to do these courses was my only opportunity to continue to grow and talk to people who were treating, see more cases, because otherwise there was nobody that I could bounce ideas off of as to, was I doing it right? Was I doing it wrong? So it was almost a must-have that I needed these courses to just be available to me to be able to continue to have it make sense.
Yeah, it's developing a skill. Developing a skill when you take more reps. Every person you work with, you get better at fine tuning really what they need, because as you and I both know, every person is unique in how we prescribe treatment to them and what fits their particular unique medical history and presentation, right? So,
Yeah,
yeah.
and when we'll do continuing education, but when we do continuing education after graduation, we've already learned what's going on with the shoulder. We've already learned what's going on with the knee. So these weekend courses are adequate to help us brush up or improve on our evidence-based research. But with scoliosis, we're never taught this. So these
Mm-mm.
certifications are several years long. And so, I see some posts out there by chiropractors that say this is a 2-day course and, don't trust these people. And it's such misinformation that's
Mhm.
out there about this work that we do. The people that are in it, they dedicate a lot of time and a lot of funding to do this stuff well, and it takes years for us to get good at this.
Yeah, yeah, that's really important. So, what I want listeners to really take away from that is this is very unique and specialized training that is not part of traditional physical therapy education. And you have a skill set that the majority of us don't have.
Yeah.
That's really, really specific to management and treatment of scoliosis. So, tell us really, what is scoliosis? What in simple terms for people that are listening to understand, what is scoliosis?
Scoliosis is essentially a three-dimensional change in the spine that involves compression, deviation away from midline, and twisting. Right? In order for somebody to have scoliosis versus a leg length difference or an imbalance, you have to see all three of those. And so if we think about a towel and we just kind of twist that towel, the more we twist that towel, the more it shrinks.
Mm,
That's our spine. And as it shrinks, it also moves away from center and twists. So that's always a good example of people being able to visualize what's happening. Is compression creates deviation, which creates twist. And those three are there, which means that when we assess somebody, when they bend forward, that twist remains and we see prominences, or, the old verbiage used to be, we used to see humps. We try to stay away from that nowadays. But we see these prominences as people bend forward that don't resolve with forward bending. Right? So if
mm.
it's just a postural imbalance, it might be somebody that looks like they're twisted when they're standing, but when they bend forward, it levels itself out. But these are changes that don't level themselves out when people bend forward.
Hmm. So as you're looking at someone, and so you're talking about, so that twisting. So as somebody is facing you, you might see one shoulder more forward and one shoulder further back, or the same thing in the pelvis. Is that something you would visualize?
Yeah, we do postural pictures from all four directions. So I usually start from the back. But yeah, we'll see a head tilted off to one side. We'll see one shoulder up higher. We'll see one shoulder blade forward.
Mm-hmm.
Might look more sunken on the other side.
Mm-hmm.
Now, for a lot of our more mature adult onset or adult scoliosis patients, a lot of the curve tends to progress more in the low back. So you might not see a whole lot of these things in the shoulders and the head, but what you'll see is one hip that sticks out quite a bit further. You'll see people leaning to one side, and depending on their compensations, they may be able to right themselves upright, but you can see that their shoulders are not in line with their hips, or maybe they feel like one leg is shorter than the other, and that's kind of a secondary perception of what's happening through the pelvis. There's twisting, there's shifting, there's leaning, there's compensations. Yeah, just kind of
Yeah.
trickles up.
So we have this change in midline where the shoulders are not necessarily right on top of the hips, or the head is not right on top of the shoulders, or all of those. There's the twisting of the towel. So that rotation that shrinks the towel and adds the compression.
Yeah,
There's a lot going on there and a
yeah.
lot of adaptation. Is it painful?
With more of our scoliosis as a condition itself doesn't have to be painful. In fact, in our younger years, most of the times people if they never go to the doctor for this, they don't get diagnosed with scoliosis because it isn't painful. People adapt very well to this, and their body has a lot of adaptations. So pain generally comes in two ways. If it's an adult onset scoliosis, then usually that person has had some sort of chronic pain, low back issues, flare-ups regularly, and so they've kind of lived in this low-grade pain lifestyle that has perpetuated, and then the spine starts to collapse. Sometimes there's no pain, but with a adult onset, because things happen so quickly, the tissues don't have time to accommodate like they do when it's a gradual progression through life. And so sometimes it hits more hard in older life because the progression can be just as quick in adulthood as it can in adolescence.
So let's talk about that. Since the majority of people that I work with osteoporosis are older adults. Talk about what triggers adult onset scoliosis. How is that happening?
Well, usually there's some sort of triggering event, right? There's a wonderful model put out by Stokes that really kind of shows a cycle of events where you have a triggering event that creates pain, that creates muscle being shut off, instability. We tend to protect, which means we usually go to one side. That puts asymmetrical pressure, which then creates asymmetrical load on the discs, the vertebrae, the ligaments, which then perpetuates more postural imbalance, which perpetuates more pain, which perpetuates more compensations. And so it just continues to trigger in this cycle.
Okay,
Yeah.
so an incident happens, and that the compensation patterns that we get without perhaps a good intervention can create this cycle of pattern that changes the shape of our spine.
Yeah, and it might be something that happens, when we're young, middle age, but those pains, those say, right back pain, you tweak it, it's better in a day. Then the next time you tweak it and it takes a week to get rid of. And then the next time you tweak it and it takes a little longer to get rid of. The episodes get a little closer together. And so as this starts happening, then muscle memory starts to change as how your body's holding you, how it's protecting, which muscles are active, which muscles are too tight. And so this can happen slowly or it can happen quickly, depending on what the underlying tissue damage is.
Is scoliosis always progressive, or can it remain stable for some?
For some, if they've had scoliosis since they were a child and that scoliosis has been lower than, say, 20 degrees, then a lot of the research suggests that there's more stability in those curves. But the research also supports that even with the most stable curves, you're going to see a 0.5 to 1 degree of progression a year. So the lower the scoliosis is to start with, maybe that 0.5 degree is really, really slow and they only increase a 0.5 degree every few years. But the closer that curve gets to 30 degrees, then there more chance of that imbalance kind of starting to progress, and that postural compensations, our habits, everything kind of leads us outside of that neutral posture zone. And pretty soon the body has a hard time holding itself up against gravity. So it's part of that progression of the load on the bones, and the weaker our bones are, the quicker the progression is going to be.
Would you say that you can prevent that progression in people that have a really mild presentation with appropriate exercise management?
Absolutely. Yeah, I've seen patients in my practice where, they say, a lot of doctors will tell you, "Oh, you can't do anything about scoliosis once you're an adult." But a lot of scoliosis it's not only bony changes, but if you don't have those bony changes to begin with, you've got this postural dysfunction, then you load the spine centrally, and now all of a sudden you give an opportunity for both sides of the body to participate equally, and you're going to be able to stabilize in center, right? So the goal is, but so many people, I come in and I use one of those carpenter's levels that I shine on people, and so many people don't even know that they're off center. And when I show them, they're like, wow, right? And
Right.
so I'll spend my first visit just getting people to find center,
Hmm.
and they'll come back after the first visit going, I feel so much better,
Oh,
because they didn't know they were there. But now they have to find themselves there more often. And so the more that you can be aware of it, the more that you can fix it on your day-to-day stuff, which is why we work a lot with a lot of functional stuff, which I'm sure you do too. How to sit, how to stand, how to sleep, how to bend. Those are the things that are critical because that's where they live. We can
mhm.
add exercises in there, but exercise is not where we're spending most of our lifetime.
Right, right. Reorienting, finding those positions in our everyday activities, and that's bringing that some mindfulness to how we move, and that is critically important for
Ex-
osteoporosis as well.
Yeah,
I,
exactly.
I have a confession that I have scoliosis. I consider it mild, and I had no idea until PT school when everyone's assessing each other, and they're like, "Things are not lining up with you, Lisa." And I'm like, "What are you talking about?" Yeah, so I've had it for a long time, and I feel very fortunate that I think the strength program and work that I've done has really kept it very, very stable. So
Yeah.
I want people to be hopeful for that as well. And
Yeah.
when you talk about that angle, is that the Cobb angle that you're talking about?
Yeah, on X-ray, when we measure the vertebrae that's the most angled in the image, and the on the top and the one on the bottom, where those two lines come to intersect, that's how the doctors measure a Cobb angle. Now, how we can also do that in the clinic is we have a scoliometer, which has got a scoliometer here.
Of course you do.
Right. So this is a scoliometer, trying to do it without my blurred vision. I may have to take there we
There
go.
we go. That's
So
good.
there's, when somebody bends forward, this is where their spinous process stays. And when somebody bends forward, as they start to move that ball, of course, this is not going to work
Yeah,
here,
yeah, yeah. I
right? That
see.
ball will move over to one side or the other. And so that gives us a little bit more of a clinical presentation that we can measure and remeasure in the clinic, that we're not sending our adults for these repetitive x-rays like we do our kids,
Mm.
right? So that helps to measure kind of where that rotation of those facets are kind of twisting up into the skin, and where
Mhm.
the muscles are collapsing down. That's what gives us that standing asymmetrical trunk rotation.
Right, right. Great. So we talked a little bit about the curve. So there's a curve that is the concave side, and then there's the curve that's the convex side, right?
Yes.
And you're going to get more compression on one of those sides on the vertebra.
Yes, on the vertebra itself, but there's compression of the disc that's
Mhm.
pushing out to the
Right?
convex side. There's more ligament stress on that convex side. There's, bony stress on the concave side.
Right.
So some people will have pain on the convex side, and some people will have it on the concave side, just because of different structures that are involved. Um,
Got you. So on the convex side, where there's going to be more stretch on the ligament and pressure into the disc. Is that what
yeah,
you're saying?
yes.
And on the concave side, we're going to have more pressure on the bone.
More pressure on the bone, more closure down on those areas where the nerve comes out.
Mm.
And people might have heard the word stenosis before, right?
Mhm.
Anything that kind of narrows the pathway.
Right, right. And when it comes to osteoporosis, that compression is something we're worried about. So when we're managing osteoporosis and we're going into safer movements or smarter movements, we try to limit forward flexion of the spine that would increase pressure on the vertebral bodies, but we also try to limit lateral flexion of the spine. And scoliosis is going to have some inherent lateral flexion in it, isn't it?
Not a lot, honestly. Not a lot. We don't do a lot of lateral flexion. We don't do any end range
No, no, no. I
movement.
mean, the presentation of
Oh,
scoliosis, that
yes.
convex side would be a functional lateral flexion.
Yes, yes. Sorry, I thought you meant an exercise.
No, no. Yeah.
Yeah, no, by inherently in nature, the scoliosis has a lateral deviation or a side bend to it.
Right.
Hmm.
So in that way, having scoliosis and osteoporosis, and I know what the literature tells us is there can be an increased risk for fracture.
Exactly. Yeah,
Exactly.
and that side profile where we're looking at people, where people are bending forward, creating more kyphosis or rounding of the upper back, that's the first plane of movement that we address in scoliosis, is that sagittal plane. How are the hips shifted? How is the upper back positioned? Where is the head positioned? Because if we can't get the head and the shoulders and the hips to be in line, then we can't make space for us to do anything side to side.
That it makes perfect sense. So the first thing you're working on is that, if I'm using the right term, that hyperkyphosis and forward head and shifting of the hips. So the first thing is to work on that. And that's a very common overlap of osteoporosis management too. We're looking for that lengthening
Exactly.
of the spine.
Yeah, that elongation of the torso, right? And being able to find that elongation. One of my mentors has always said the biggest job that we have is to fight gravity, right? We need to maintain that elongation to make space for everything from our organs to our muscle activation and balance.
I love it. Yes. So a lot of similarity there, and especially in that initial treatment phase that most people can do, right? This is pretty accessible for most people.
Exactly.
Are there any simple exercises that you could explain that someone may already be doing that they could say, oh, okay, I'm on the right track here?
One of the things that we break down, everybody talks about core, but obviously core engagement is done very poorly with a lot of people because they just think that sucking in their belly is core. And so we go through, kind of break down transverse abdominals, getting people to understand that core engagement means belly button pulling to the spine and spine pulling to the belly button, right? A lot of classes, people are still telling people to flatten their back towards the floor to get the belly button and the abs engaged. And 90% of back pain, even though it's not a scoliosis specific research article, but this article shows that 90% of back pain comes from a loss of lordosis. So we have got to maintain that little scoop and curve in our back. And so that means being able to engage our spine and our belly button toward one another and not just pulling our belly back to engage the core.
Right. And in osteoporosis management, we don't do the flat back technique anyway, too. So that's good that we're on the same page there.
Yeah.
What happens? What are the complications if scoliosis becomes really severe?
So one of the things that we usually find that starts to happen first is people will end up getting total knee, total hip replacements, even total shoulder replacements, because the arms and legs and things that are creating so many compensations, they actually wear out before your back does. So, these people are getting total hip and knee replacements, but their hip shift is never being controlled. And so, they're getting all of these other medical treatments to treat symptoms, but never getting to the core. So we'll see other unessential surgeries that are happening. We'll see breathing difficulties. People will start to collapse forward, which will start to present with shortness of breath. Then we start to see increased fall risk, because if you've got yourself forward of your center of mass or sideways, now you're having difficulty with picking up your feet and moving forward and backwards and those kind of things. So yeah, really increasing fall risk, increasing, I won't say non-essential surgeries, because obviously once we have these joints wear out, they are essential, but really surgeries that are dealing with symptoms, shortness of breath, that people start to be put on, ventilators and nebulizers and all sorts of things to help them breathe, but never really unloading through their chest and their diaphragm so that they can breathe. So yeah, balanced breathing and muscle imbalances and wear and tear, I would see a lot of.
I think this is really key. And key as we're talking the overlap of osteoporosis management, which is fracture prevention. Yeah. When we have these postural positions that we know put us at increased risk for balance abnormalities and falls, having our head come way forward of our body, our visual orientation is lower than it would be in a normal posture. And then the shifting of our pelvis, so we have more imbalance between left and right leg. increases that risk for falls, and falls cause 80 to 90% of all fractures. So that is a huge part of the importance of management in these two conditions.
Yeah.
And then breathing, without a doubt, losing that aerobic capacity, functional capacity. I have worked with clients that they can't maintain normal oxygen saturation levels because of such severe scoliosis and compromise on their ability to expand their lungs, which also puts you at risk for pneumonia.
Yeah,
right.
exactly.
You can't get that full breathing in. So I think one of the things that's really becoming clear as we're trying to pull these nuances out is your treatment is very specific. It's very specialist indicated. And so whenever someone has the opportunity, they should work with a specialist. How do they find someone like you?
Generally, we've gotten much better now at being able to have registries through a lot of the credentialing of therapists through the different boards. So a lot of people, if they know the word Schroth, that will usually pull up some of the websites that are giving listings underneath the different credentialed bodies. So, but yeah, if you don't know Schroth, then, usually Scoliosis Physical Therapy is coming up with things now. And I have to say, it's not in every state, so what we're finding is still a shortage of PTs out there that want to do this work or available to do this work. So some states are completely devoid of even having one therapist in them. So there's a bigger need for more therapists that are doing these specializations, because otherwise people are either going through Zoom or they're traveling to other states to get this stuff done.
Yeah, there's a big gap in care there. Similar for osteoporosis management as well. So I hope other rehab professionals maybe are inspired by this.
Yes,
if
I
they
hope
see
so.
it, to also want to reach out, because it's incredibly meaningful work. Are there some exercises that or modifications to traditional strength training of lifting weights from squats and deadlifts, bicep curls? Are there any modifications that a person that maybe has a more moderate or severe scoliosis should consider?
It's so unique to each person that it's really hard to give directions, but for example, if we have a curve that deviates to the right, then that generally means that that person is going to have weaker low back muscles on that right side. Even though a lot of people will go, I feel like I'm really tight on this right side, and so I have to make sure that they understand that that prominence that they're feeling is not actually that the muscles are stronger on that side. They're actually weaker on that side, and it's more prominent because of the twist of the bones, right? So people are often working the wrong side because they're working the flatter side, thinking that that's the weaker side. And so when we look at somebody from the back, where that deviation goes, that tells us that that side of the low back, that side of the glutes, that side of the hamstrings, everything on that posterior side of the body is going to be weaker. The partner to that, because we're not robots, is not directly on the other side, it's on the front of our body. So what's weak on the right posterior is going to be weak on the left anterior. So hip flexors, quads, glute medius. So we really have to be working asymmetrically with these people, which means that lunges, being able to open up that concave side, knee down on that left side, doing a right side lunge. More glute medius activation, so single leg standing is going to be weaker on that left side because their hips shift to the left when their upper back goes to the right. So yeah, it's about kind of taking something that's sitting here and getting it here and here to be pressed in. So we can't be working, it drives people nuts to not work symmetrically, but we have to teach them they're not starting off symmetrical. So they don't have to worry about getting, overly strong if they're avoiding doing exercises on one side. They need to bring themselves back into balance. So a lot more glutes, hamstrings on the side of the convexity, and a lot more hip flexor, quads, those kind of things on the concavity, which helps to fill up the concave side of that curve.
Okay, that's like really specific to that person
Yeah.
and that curve. But I'm going to ask you if we can make just
Okay.
a general statement about, is it okay for somebody to do squats, or would you tell them not to do them?
No, squats is good. The difference between what we do in osteoporosis and scoliosis is that the principles in scoliosis are trying to unload the spine, so we
Mhm.
wouldn't use a barbell on the shoulders.
Oh,
We would
makes total sense.
Right,
Yeah.
we would use kettlebells, we would use hand weights. So we really try to avoid loading the spine until the person is strong enough to actually be able to resist that. So our principles through Schroth are all about elongation. So we do this concept of a semi-hang, where with people whose shoulders can tolerate it, we're stretching out, but we're creating active assisted, almost like you'd be doing a pull-up with your feet on the floor, but you'd be doing it just with your shoulders. You're not doing it with your biceps.
Mhm.
But people can do squats. One of the biggest thing that I find with squats that people do incorrectly is they don't maintain the curve in their low back.
Mhm.
Right?
Mhm.
Lunges, we might do lunges more on one side than the other. Planks, if we're doing planks with people, we would, if they have an upper curve, we would want to make sure that the arms were asymmetrical. But planks are good, right?
Love it. Love it.
On a side plank is good, but we have to consider what's if they've just got a lower curve, then that's great. Then we do it on the side of that convexity so that they can be helping to lift that curve up to center, and actively working those muscles. So, yeah, depending on which activity my patients like to do. If they come in and they love to do Pilates, then I'll do modifications on the reformer. If they like to do yoga, then we'll talk about modifications in some of their twisting activity and trying to stick more to one side than the other. If it comes to weights, then we talk about how to asymmetrically strengthen. But nothing's ever off the table. It's just
Great.
like, know
Great.
your body, know how to position yourself first, know how to maintain your alignment with your curves, and then you work from there.
Great, great, great. I love that. Okay, I just wanted to make that clear that there are still things that people can do if they have both conditions, that it's not necessarily dangerous, but you're more conscious about not reinforcing bad patterns and helping to improve kind of weaker and stretched versus short and strong sides.
Yeah, no, I love it. I've got a 77-year-old patient that's got an 80-degree curve and she's totally pain-free. So these things do not have to be painful. If you know your center and you can maintain your muscles around the curve, you're going to be able to stabilize, potentially even improve the curve, but you're going to be able to keep those muscles as strong as possible. So, yeah, activity, hands down, is definitely, necessary to keep the body strong.
Yeah, strength is an asset into
Yeah.
maintaining that position. So strength is always going to be an asset there. That's wonderful. So tell us a little bit, just briefly, what does somebody experience if they come into your clinic to work with you? And you have other therapists there too, as well, right?
Yes, yeah, I do. So the first thing we focus on when people come in is obviously doing an in-depth assessment. So we do seated height, sitting height, and standing height, because people will shrink as they kind of go through all this, and we really want to get people to pay attention to their posture.
Mhm.
We'll do their forward bending. I'll have a look at their x-rays. We'll look at their pain complaints. And then the first thing I start to do is I start to show them how to sit, how to sleep, how to stand, how to bend. Those are kind of the functional things that they can go home and do some homework in. Am I always sitting on one side? Am I always leaning to one side? Am I using one arm more than the other? Those kind of things. So trying to really get them to start to self-assess
Mhm.
what their living environment looks like and
Yeah.
how they're living in it. And then we start to work on core, and then we start to work on breath work. And so
Mm.
we really want to make sure, and I know breathing is the fad everybody seems to be going with nowadays, which is amazing. We get caught up really being mouth breathers. So in our work, we try to focus people on breathing in through the nose and not only breathing out through the mouth, but focusing on really an elongated exhale
Mm.
through the mouth, because tend to be very shallow breathers. And it's not about getting more in, it's about getting enough air out of our lungs that recoil can pull more air in. Because if we don't exhale long enough, then
Mhm.
we've got crap that's stuck in the bottom of our lungs. And so our inhale is not going to help us. We need to really learn how to exhale. And so that's a big thing for my patients. They've never really been talked to about the importance of a full, complete exhale.
Yeah,
You
yeah.
know?
I love that. I like to give the example of the canister. And if you're just exhaling this far, and then you're only filling up this far, but if you
Right.
exhale all the way, then we can fill up all the way. And
Yeah.
I love that you talk about the breathing and the breath work, because I think this is critical too. And it's not just how it affects how much air you're getting in. That slow exhale is a bit of a core exercise as
It
we
is.
do that.
Yeah.
And it also is regulating parasympathetic nervous system to be more anti-inflammatory, more decreasing pain, tone, spasm, tightness. It is our rest and relax nervous system. So these long, slow, deep breaths are incredibly beneficial for stress management. And who doesn't need that
Right.
right
Yeah.
now?
Yeah.
Right?
And our ribs were intended to move more than just up and down, right? So we
Yes.
really work a lot on that exhale and getting people to feel the rib cage expand. And as they're able to expand, a lot of times those lower ribs are involved in that curve. So if we can get the air down to those lower aspects of the ribs and the lungs, then we can get that concave side to start filling up. And that's just something that they do all the time. So that's so much more efficient in the oxygen that they're getting to the body, which gives them more energy, which means that they can hold themselves up against gravity, which means that there's less compression, and it just flows through positive outcome.
Wow, this is so great. So great. I love all of that. And I love really this specific skill that you have in your clinic, and the way that you can serve people and really help them thrive despite having scoliosis. Let's recap a little bit. So one, I think one of the most important things is having a specialist whenever possible to be able to assess you and make specific recommendations for the type of changes that you find in the assessment that work for them. So whenever possible, right, see a specialist in scoliosis management. The next is to work on the common things between osteoporosis and scoliosis, which is lengthening, finding length in that spine, that sagittal plane position that you talked about. So we know that that can be beneficial, simple. They don't have to be complex exercises, and almost anybody can work these. And often they're worked in the supine, laying on your back position, and can be done very, very easily. Next is, it is beneficial to improve strength, right?
Yes.
Strength is going to be supportive, and learning the right ways to stand, to sit, to walk, to do daily activities can make a big difference in protection, and then preventing things from progressing. Yeah.
Yeah.
You mentioned one thing. I want to circle back to it really quick. You talked about measuring height, and I always recommend people measure their height. I say once a month, same time of day, same location, bare feet. And we look for a 2 centimeter difference or more between measurements as a risk for a fracture.
Okay.
Yeah. So in osteoporosis training, that is an indication of a potential risk for a fracture. Now, just saying that can be really scary for people to think about. Okay. And often in the postural training exercises, people will see an increase in their height, which is wonderful, right?
Yes. Yeah, they love that.
But I like this tool, this self-assessment tool, because how often do we'll have a little tweak or a pain and we automatically go to, oh, did I fracture?
Yeah.
And so if we're taking those height measurements and you can see that there's been no change in your height, well, that's a nice self-assessment tool to see. And maybe we can just give it a few days and that pain goes away and we don't have to stress about a fracture. But if there was a change, that's an indication somebody needs to talk to their doctor and get an assessment.
Well, in the scoliosis world, a 2 to 3 centimeter change is also an indication that there's been some increase in the Cobb angle. And so we watch out for that as well. Yeah.
Yeah, I think that's a great assessment tool for people, and a lot of folks can do that themselves too.
Exactly. Yeah.
Yeah, great. Well, before we wrap up, is there anything else, any other message you would want to give people that are listening that maybe wonder if they have scoliosis or know they have scoliosis? What message would you want to leave with them?
I think knowledge is power. I've always subscribed to that. And it's like, if you think you have something, then talking to somebody will at least allay your fears. Maybe you don't, but having somebody be able to look at your posture, look at your centralization, be able to look at what you're doing already in your lifestyle. I mean, it's always good for a specialist to be able to, fill in the pieces of the puzzle. You may have a great workout, great nutrition, great routine. But if something is missing, then it could be that one or two things that stops you from having a flare up.
Mhm.
So, knowledge is power. If you think something is going on, or if you think something has changed, one shoulder's higher, find somebody that says, yeah, I see what you're talking about. I'm validating that what you're seeing is correct, but this is what you need to do for it.
Mm.
And most therapists, I think people are sometimes afraid they're going to go to therapists and the therapist is going to tell them to stop doing things.
Right.
And right, and that's definitely not the experience that I've ever given with my patients. It's like, we want you to stay active, but okay, let's see how you're doing this. Great. Keep doing your squats, but a little bit more scoop, a little bit more tummy engagement. Good. I like how you're doing overhead press, but let's not do it with a barbell. Let's do it with hand weights, right?
Mhm.
So there's always knowledge to be gained. And the more that you know about yourself, then the longer you can do everything that you want to do. Scoliosis has never stopped people from having a strong, healthy life,
I
right?
love
You
it.
just got
I
to
love
stay
it.
on top of it.
I love it. Yes. So really, you want to empower people to take action so that they can stay strong and independent and active in doing what they love. Right.
Yeah, and these two conditions do tie themselves very closely together. And so, understanding your bone density, getting a full spine x-ray at some point, in your life as a reference point, I think those are all, very um, good proactive things to do.
Awesome. Fantastic. Well, this has been incredibly informative. I've learned a lot today, and I really hope those that are watching and listening really take some key takeaways from this as well. I thank you so much for your
You're welcome.
time. If people wanted to find more information about you, where should they look?
Yeah, my website is ScolioAustin.com.
Great.
And so there's information, I've got blogs on there, information on there. If anybody wants any further information, they can always reach out to me on the website.
Fantastic. Well, I'll make sure that we link that below in the video on YouTube. And once again, Danielle, thank you so much for your expertise and your compassion and your care of clients with scoliosis.
Thank you, Lisa. I appreciate you.
Okay.